Welcome back. Hope you had a nice break. So we are ready for our final scientific session of the day entitled Reconciling Personalized Nutrition and the DGA. Should and could dietary guidelines be personalized? So I want to encourage our virtual audience to continue submitting questions and comments throughout. And for anybody who wants more information about our speakers, all the bios can be found online. So I am pleased to introduce the moderator for our session, who is Dr. Carmen Tequay. She is an associate professor in the Department of Epidemiology and Biostatistics at Indiana University School of Public Health and also serves on our IFAN Scientific Leadership Council. Come on up.
Thanks, Alex, for the introduction. We have a very exciting session with 4 great speakers today, and what we'll do is we'll have all the speakers speak first and hold all the questions till the end. So our first speaker is Dr. Allison Steiber, and Dr. Steiber is the Chief Science Officer at the Academy of Nutrition and Dietetics. She will be sharing the perspective of the Academy of Nutrition and Dietetics on personalized nutrition. Dr. Steiber.
So thank you, Carmen. I can't tell you how exciting this is to actually had to walk up to a podium and I get to see your faces. And if you're looking, slightly bewildered by what I'm saying, I'm going to know it. Unless you're wearing a mask, I might not know it then. But it's super exciting to be in person today. And I think this is such an interesting topic. We've had a bunch of conversations between those of us who are panelists about the topic in general and how large it is and sort of intimidating. But it certainly, hopefully, will foster some thinking by you all and hopefully further conversations. So I'm going to not use that because the arrow thing doesn't work. So here's me. And here are my disclosures, and I'll leave them sit for a little bit. But the primary disclosure, I think, for you all to know is that I do work for the Academy of Nutrition and Dietetics, and we do have a vested interest in this conversation, obviously, because of our membership. So I'm starting out with a little cartoon, and I'm starting out with this because, when Marie talked to us about this topic and talking about it from the perspective of the Academy of Nutrition and Dietetics, I think that when we have to have these conversations, we have to begin with what do we mean by this terminology. When you go into Google or you go into PubMed, you can look up personalized nutrition, you can look up precision nutrition, you can look up, there's a whole bunch of terms that are circulating. And so I think maybe starting with what do I mean when I'm talking about this, and I'd like to start with the definition that was put forth by Adams et al. A number of years ago in the Advances in Nutrition article, and that's that personalized nutrition uses individual specific information found in evidence-based science to promote dietary behavior change that may result in measurable health benefits. So when we think about that definition, it's actually a pretty narrow definition. It's really focusing on dietary intake. I think that as you go through and hear about our panelists, you're going to hear about us coming from different perspectives. My perspective is very much thinking about the practitioner, but you're also going to hear Dr. Studi talk about population and how we think about influencing the population. You're going to think about equity a bit. You're going to think about food and how we design food to change and dietary behavior. So I think that from my perspective, I would like to set out a framework in which we're not talking about these as individual siloed targets. We're not talking about, well, we either do personalized nutrition or we have dietary guidelines for Americans. We're talking about how do we do it as an and. How do we think about having effective dietary guidelines that reach in an equitable way the population within the United States, and we have mechanisms for equitably providing nutrition care. And thus we can change outcomes in a meaningful way. And I think we can agree that perhaps we have not done that particularly well in the past, that we have a lot of opportunity for improvement. So in an interesting twist of fate in my mind, when I looked at the strategic plan from the NIH on nutrition research, their definition of precision nutrition is actually broader than the one that I've just provided you by Adams et al. And so in this definition, it says precision nutrition is a framework canvassing a wide array of features, including genetics, dietary habits, eating patterns, circadian rhythms, health status, socioeconomic, psychosocial characteristics, food environment, physical activity, and the microbiome. And so I want you to kind of remember these definitions as I talk a little bit about what we're thinking of when we think about personalized nutrition. I will give also the caveat that we have a bit of a biased perception as dietitians because we sort of feel like we've been doing this forever, that this is our shtick. We do personalized nutrition. And so I'm going to say that in the context of, everything I present to you today. So also I think that it's sort of important to get a lot of these, jumble of words coming out that we think about when we hear people talk about personalized or precision nutrition. Some people take it, looking at that elephant and just look at the trunk and say it's just about genetics. Other people are really focused on microbiome. People are talking about glucose monitoring. People are talking about bio feedback mechanisms, whether you wear a smartwatch or you wear some other kind of biofeedback mechanism. So, I think all these are of value and interesting, but because there's so many omics to be considered, I think it's hard for us to know, is it effective as a way to improve health in our population? Because we're not talking apples to apples. We're talking about a variety of different interventions in combination or in silo with nutrition care and counseling. So everything from nutrition genomics, which I'm going to kind of focus on initially, the nutrigenomics aspect, but there's also proteomics, metabolomics, etc. So this is data from my team in which a couple of years ago in 2018, we did a scoping review. So those of you who aren't familiar with a scoping review asked the question of what is the level of evidence that exists in the literature about a particular topic. So some of our practitioners came to us and said, we're very interested. We really think that there's been a movement in nutritional genomics, and we want to understand what the lay of the literature is. And if there's sufficient evidence, can we then go on to do a systematic review to shape guidelines for our practitioners? So these are not guidelines that would face the public, but rather would face practitioners. And so you can see nutritional genomics is one aspect of this precision nutrition. It describes how the interaction between genotype and diet affects health outcomes and how diet can influence gene expression. So as you can see, and I can't effectively use the pointer on both sides, and since I've been told not to choose a side in DC, I will not do that. However, you can see by either side that there's been a great uptake in studies that have been conducted. And in fact, when we began to search the literature in the scoping review, we were amazed at how many studies that have gone up. And so you can see some looked at gene type guide and nutrition care, and sometime looked at gene type disclosure only. But both were increasing in the literature. So we took a little further look, and as we scoped through there, we could see that we found 32 papers that met our inclusion criteria, and of those, we had 14 randomized clinical trials that were looking at genetics. Now, that was back in 2018, so indefinitely there are a ton more that are out there, and every day it seemed like we're increasing the amount of literature. The question, I think, is have we reached the tipping point where there's sufficient positive literature to allow us to have change in practice from a nutrition professional perspective? And I think that's still in a bit of debate. I mean, the average person who has a smartphone and wants to download an app can find apps that will tell you that they are doing personalized nutrition, and they probably are. And so certainly our population, some aspects of our population are going there. But the question is, when we say we have an evidence-based profession and an evidence-based practice, that means there has to be a certain accumulation of sufficient evidence to warrant it, right? So we want safety. So I just want to show you some of the big outcomes, and I'm sorry, the screen is small, so I'll try to give you a scoop, but some of the outcomes that they were looked at were dietary intake of specific foods or nutrients, changes in general dietary intake, biomarkers, anthropometric measures, body composition, quality of life. So you can note there that these are predominantly surrogate markers, that you're not seeing mortality here, for example. You're not seeing composite markers of cardiovascular disease. Like some of those harder outcomes, we are not seeing as much, at least at that time the scoping review was conducted. But these are more surrogate indicators, and I think that bears noting. So we felt that there was sufficient evidence to move forward and do a systematic review. And to do a systematic review, we wanted to create kind of a framework that will allow us to think about the evidence that we were analyzing and hopefully going to be able to do a meta-analysis on. And so we thought about this in two different ways. So we thought about study design A and study design B. With study design A, thinking that both groups, your intervention group and your control group, both got nutrition counseling and care, and the intervention group that we were really seeing is their additive effect also got genetic testing information. The reverse was true with study B, study design B. There, both groups got the genetic testing, and nutrition counseling was the additive piece. And so then we wanted to look at dietary behaviors. We wanted the studies to have dietary behavior information and intake outcomes, to look at intermittent outcomes, and if possible, look at hard outcomes. And I will say that there really were not hard outcomes that were able to be analyzed in a pooled analysis way. So what you're going to see, not really well here because it's very, very tiny font, but I'm going to tell you, and you're just going to have to believe me, that there were no significant differences between the groups. That at that time, that these were 14 randomized clinical trials that were included within this analysis, that we were able to do some tiny meta-analysis, and no statistical significant differences were occurred. And so we published a consensus paper saying that this was an emerging area, that it was constantly evolving, but at this time we could not conclusively say that the adding genetic testing information to nutrition counseling provided improved outcomes. And that's where we were. So I'm going to give you this incredibly simplistic, and I'm a little horrified by it because it doesn't include a lot of important factors, but I'm going to show you this little way of thinking. You know, I think the United States has such enormous inequity in how we deliver healthcare. I do not have a reference for that, but that is the Allison perspective. We have huge inequity. And so it is very difficult for us to say, well, we are going to, we don't believe dietary guidelines work. Instead, we are going to shift gears and think only about personalized nutrition or personalized precision medicine. Because of the inequities inherent within our healthcare system, that puts it at a great disadvantage for a whole lot of different individuals. And so instead, I think we need to have an additive, multi-pronged approach where we think about the US population at large and think about how can we provide both population-based guidance to the masses and try to provide as much access to healthcare providers, whether they're dietitians or just your dietitian nutritionists or exercise professionals and other public health professionals, so that we get an additive benefit and we improve the outcomes in our population. And that's taking into consideration all the myriad individual circumstances that people are faced with every single day. Right? So to think about that, I'm going to show you just a little bit of information from a registered dietitian nutritionist perspective, in which we think about what we do as personalized nutrition, and we do that in two kind of different ways. Most dietitians practice in what we think of as the nutrition care process, which allows us to have a framework or a structure around our process. And medical nutrition therapy, to those people with conditions, healthcare medical conditions, is the primary intervention. But we also do lots of preventive work and population level work in which we think about how to prevent things downstream. And we can do that leveraging the dietary guidelines. We can also do that in a way that promotes individualized, personalized care. And I'm going to show you a little bit of data that we've just published in the past couple of years on the effectiveness of that approach. So this is another scoping review. Yes, I really like scoping reviews. So I like this one from various reasons, but this data was generated in a collaborative approach between the American Council on Exercise and the Academy of Nutrition and Dietetics, where we came together to ask the question, what is the impact in the general population of care by a registered dietitian nutritionist or an international equivalent and an exercise professional. And so the scoping review, of course, doesn't say whether they're effective or not, but it tells us where the literature lies and the type of literature. And so the two first things we really wanted to know was the impact of those professionals and is there evidence on that? And the second was, what is the evidence around mobile apps and wearables? Is there evidence? Because you can imagine that those are pretty achievable add-ons when we think about personalized nutrition, thinking about bioactives and wearable types of data. So as you can see that in the nutrition, the counseling on the top row with kind of the palest bubbles, and each bubble represents the number of studies for a particular year. So it starts back in 2004 and goes all the way to 2020. And you can see, in 2008, there were 4 studies that were published that met our inclusion criteria for this scoping review that had around counseling, nutrition counseling by a professional. And then, you go on through the years. Wearables were not as prevalent. The studies weren't as prevalent early on, but have become much more prevalent. And then the bottom one is ergogenic supplements. And as you can see, there's been a plethora of studies throughout the years on that. So 139 studies were included in this broad scoping review, and I think that the data is kind of interesting. So when we again give a heat map to look at what were the outcomes that were looked at and who was delivering the care, which I think is sort of interesting as well when we think about bandwidth and staffing, capacity. So in 20 studies, we had a nutrition and exercise professional working together. In 14 of the studies, we had only the dietitian, and in 2 studies, we had only the exercise professional. And you can see that there's a plethora of outcomes that were looked at, some of them hard in. So mortality was not looked at across any of the studies, and we tried to determine that. There was a little bit of quality of life, cardiovascular disease, type 2 diabetes, metabolic syndrome, nutrition status, etc., were some of the outcomes reported in those papers. From this scoping review, we found that there was sufficient evidence to move on and think about a systematic review that would ask the question about the effectiveness of the interventions in the general healthy population by these practitioners on health outcomes. So, and I'll read this a little bit to you and explain it, but the results, in my opinion, were fabulous. What they really showed was that it was statistically significant results. They showed an increase in physical activity after the intervention, an increase in vegetable intake. So the words that say low, moderate, high, that's the grading system for how much certainty we have with the evidence. So the physical activity was low certainty, but it was still statistically significant. The increased vegetable intake had moderate level certainty. The reduced waist circumference had high level certainty, and the likelihood for achieving a 5% weight loss for adults who were either overweight or were living with obesity was high. So that is really impressive to show that in the general population, we had those kind of statistically significant impacts. You might see that in a more unhealthy population, but we were very pleased with this. The meta-analysis that I'm showing the forest plot for here is for fruit intake. I don't know why I picked fruit, but I'm showing you the fruit one. There's also a vegetable one and a physical activity one and a few others. And the reason I want to highlight it is because they looked at the healthy population, but they also looked at a population with cardiometabolic risk. And you can begin to see a differentiation even in the group with risk. So the healthy population was clearly, with little heterogeneity, showed that the intervention was effective. But the population that had cardiometabolic risk had more heterogeneity and was not statistically significant when a sub-analysis was done. And I think that's an interesting thing for us to note when we think about responders and not responders and individualization of our care plans, that we even have to take into consider the subtle shift from healthy to risk. So this is an incredibly busy slide. And the reason I'm showing it to you is because the field of nutrition and dietetics, I think, is a little daunted by this idea of personalized nutrition with the addition of microbiome, like the PREDICT trial showed, or the addition of genetics, that I think are perhaps just a bit beyond the scope of what most dietitians feel comfortable with having a dialogue with their patients, their clients, and the population that they serve. And so this was just recently published in the Journal of the Academy of Nutrition and Dietetics in 2022, and it's basically a care map for getting dietitians to think about what do you do if you want to begin to incorporate genetic information into your care of your patients and clients. So I'm not going to go through all the little bubbles because I'm pretty sure she would start waving a card at me that I was over time. In fact, I just got one. Instead, what I'm going to tell you is there are four main groups, four main steps. The first one is educating the healthcare professional about the incorporation of nutritional genomics. So first, you have to make sure that your healthcare professional understands what they're trying to assess and what they want to then incorporate into the care plan. The second is really making sure that the patient is on board, and that would be a whole nother discussion, but that I don't have time to address. But ethics, there's a lot of ethical consideration, there's a lot of personal choice considerations, there is cost and resources consideration, and whether or not your insurance would cover it. So really having an informed, open dialogue with the person who's thinking about having this as part of their care and assessment. Then the third is getting the information and interpreting it clearly and accurately, and beginning to create a care plan in conjunction with the client or the patient so that they are walking hand in hand with you on what this information means and how they're going to incorporate it into their lifestyle changes. And then finally, of course, is our friend monitoring and evaluation, which we all say, but is really hard to do. And that means repeated measures of thinking about what are the health outcomes of interest, and are they changing, and did that genetic information assist in the changing of those outcomes or not? And I think that's the big question. So given my lack of huge amounts of time, I'm going to end with the list of guiding principles that are in the Adams et al. Paper. I encourage you to look at it if you're interested in this area. These are not out of the universe. They're very common. They're very reasonable guiding principles, but they're probably harder to use, particularly number 2, which is use validated diagnostic methods, right? I think that is a big stumbling point for some, especially new innovative tools that are coming out. Have they been validated in the target population? Have they been validated across the lifespan? I think those are all questions that we need to think about and ask. And then, of course, using data-driven recommendations that are validated, being evidence-based, having a grounding in science. I think that's how we build trust in the population, and without trust in the population, this is going to be chaos, if it isn't already. All right. Yes. So what did I say? Basically, I said personalized nutrition is a rapidly growing field. It combines traditional assessments, with what dietitians have done historically, with molecular markers and other biofeedback types of tools, and that are very interesting and novel, but we may not have all the evidence that we need yet to implement. We do have some evidence to indicate that the traditional methods work. The question is access. Do we have access to the traditional methods? And then finally, of course, what everybody always says standing up on a stage is we need more research. And so I will end with that. Thank you.
Thank you, Dr. Steiber. We'll move on to our next speaker. Our next speaker is Dr. Eve Studi. Dr. Studi is the Director of the Nutrition Guidance and Analysis Division of USDA's Center for Nutrition Policy and Promotion. She will be speaking to us today about personalized nutrition and the future of dietary guidance.
Excellent, and lovely kind of opening to this conversation. Really excited to be here with y'all today. And like I think several others here, this is my first time to be in a room with like other nutrition scientists all at the same time. It's really exciting. So very nice to be here, and really appreciate being part of this conversation around personalized or precision nutrition. Okay, so I'm going to start with just a little bit of background, talk a little bit about what the dietary guidelines are and the evidence base that informs them. So the dietary guidelines serve as the cornerstone of federal nutrition programs and policies. So we inform a number of the food programs at WIC, SNAP, all of those sorts of, not SNAP, WIC, school meals, all those sorts of programs utilize the dietary guidelines in their programs. We provide science-based advice on what to eat and drink to promote health, help reduce the risk of chronic disease, and help meet nutrient needs. We are mandated by law to reflect the preponderance of scientific evidence and to be published jointly by the U.S. Department of Agriculture and the U.S. Department of Health and Human Services at least every 5 years. And there's kind of a key piece there that we often speak a lot about is this understanding around the preponderance of scientific evidence. And so kind of building from Dr. Steiber's remarks, we really are at this point kind of trying to think about, is there evidence to support a preponderance of evidence to inform guidance? The latest edition of the dietary guideline was published in December of 2020, and I'll talk a little bit about that as we go forward. So thinking about the nutrition landscape, there are a number of nutrition recommendations, and this is kind of an overview of how they all kind of fit together. And I think each of these has precision nutrition implications. So the first is kind of thinking about those nutrient recommendations, how much calcium. I'll say some of the macronutrient DRIs are underway. So if you're interested in that, that is a process that is supported by the federal government, but actually implemented by the national academies. We support the development of food-based dietary guidance, the dietary guidelines, and our focus is really on health promotion and disease prevention for the general population. We do utilize the nutrient recommendations, but provide more food-based guidance. And then, of course, there's clinical guidance, including a number of things. A&D is a great example of that implementation to support particularly disease treatment. So updating the dietary guidelines is a multi-year, multi-step process. The first step, this happens every 5 years. We say, okay, what's happening in nutrition science? What are topics that we need to address or we would like to consider the evidence around in this upcoming edition? So the first step is just saying, what are the relevant topics? What are the important topics? And we have a number of criteria for prioritizing those topics. We then appoint a dietary guidelines advisory committee who conducts an independent scientific review of the evidence. The next step, and they provide advice to the Department of Agriculture and Health and Human Services to inform the next step, step 3, which is the development of the dietary guidelines themselves, which then in stage 4 are implemented throughout federal policies and programs and through other nutrition professionals and more. The dietary guidelines have always been evidence-based. Since the 1985 edition, USDA and HHS have convened an external scientific advisory committee. That's step 2 of the process. Of course, science has grown over time, and we've learned more, but we've always had that foundation where we're asking an external committee to provide us advice. There's public comments involved in that, there's public deliberations involved in that, but it does have that scientific foundation. I'll note that over the course of these last 8 advisory committees, we've had the opportunity to work with about 100 of the nation's leading nutrition scientists to inform this portion of the process. So just as science has evolved, the approaches to review the evidence continue to evolve and advance. Our earliest editions of the dietary guidelines were informed more by narrative reviews of evidence, which were totally appropriate and used across the board in informing guidance. So really standard with the time. In 2005, we introduced food pattern modeling and data analysis, so just some additional tools to assess that evidence. In 2010, we introduced systematic reviews and have continued to refine that methodology such that in 2020, systematic reviews, food pattern modeling, and data analysis were our approaches to examine the evidence. And as noted at the bottom of the slide, continuous quality advancement is really key to our work. So while we've done some of these things for many years, we continue to advance those methodologies. So looking ahead, we are continuing to advance our systematic review methodology to look at things such as meta-analyses, continuous evidence monitoring, advancing our food pattern modeling methodology, and particularly probably relevant to the precision nutrition conversation is looking at applications of system science into the methods that inform the dietary guidelines. So our guidance has also evolved as nutrition science has advanced. Early advice, and on the left-hand side of the screen, you see the 1980 edition of the Dietary Guidelines, and that guidance really focused on nutrients. So there's, which I realize it's both a screenshot and tiny, has that focus on fat, saturated fat, cholesterol, starch, fiber, sugar, sodium. So very much more of a nutrient focus. In our latest edition of the Dietary Guidelines and in more recent editions, we've taken more of a pattern approach. So thinking about the combinations of foods that people eat over time. So less about the individual nutrients, but more about the pattern of consumption over time. There's also a lot more quantitative information, just as we've learned more. There's more information from nutrition science that we can integrate into our guidance. So Dr. Steiber also provided a screenshot from our latest edition where our tagline is to make every bite count with the dietary guidelines. This edition of the Dietary Guidelines takes a life course approach. It's the first one to have chapters devoted to each stage of life and really highlight special considerations for each of those different life stages. I highlighted the chapter 2 there because this is the first edition since 1985 that has guidance for infants and toddlers. So we are excited that the dietary guidelines now cover from birth through older adulthood. The guidelines themselves, we have 4 overarching guidelines that are supported by key recommendations and then supporting text in addition. The guidelines as highlighted there are to follow a healthy dietary pattern at every life stage. The second is to customize and enjoy nutrient-dense food and beverage choices to reflect personal preferences, cultural traditions, and budgetary considerations. The third is to focus on meeting food group needs with nutrient-dense foods and beverages and stay within calorie limits. And the fourth is to limit foods and beverages higher in added sugars, saturated fat, and sodium, and to limit alcoholic beverages. And within that, just to note that within the individual life stage chapters, there's discussion about those major sources at different stages of life. So I'll pause here just to kind of reflect a little bit around this conversation around personalized nutrition. We do feel like the dietary guidelines in our current edition does consider information relevant to personalized nutrition. So the evidence review itself does include individuals representative of the US population. It does have all ages, pregnancy and lactation, a range of health status. It's not just for healthy people. The evidence base is not just composed of people who are healthy, a variety of, across race, ethnicity, socioeconomic status, and consideration of current consumption. Of course, across nutrition science, there's more work to do in every single one of those categories, but the evidence base does reflect the US population. The dietary guidelines are also a framework. They are not a prescription, and that's something we've really tried to communicate even more so this round. This is not a prescription. It is a framework that's intended to be customized based on a number of factors. That's individual needs, your age, sex, height, weight, physical activity level, pregnancy or lactation status, personal preferences, cultural traditions, budgetary considerations. So this isn't everyone must eat the exact same thing, the exact same foods over time. It is intended to be tailored and customized. There are core components, but there is a layer to do some customizing. So one of the topics around precision nutrition is kind of thinking about, okay, we have these factors. Will precision nutrition add some more factors there? Are there additional things other than age, sex, height, weight that will eventually be in that running list? And so in another discussion point is it really, is it a nice implementation tool to put into kind of the fourth step of the guideline development? Okay, so input of topics in the process to develop the dietary guidelines. So precision nutrition, it is, while it's been around, it's still a relatively new topic. So how do we integrate this or any other new topic into the process to develop the dietary guidelines? And I'll say there are many different inputs. The first is around building the evidence base, which Dr. Steiber spoke to, and that's something we continue to monitor. Then we say, okay, is this something that there's enough evidence that we should really explore this question? Is it a new question? Is it refining an existing question that we already have? So thinking about what questions need to address this topic to potentially inform guidance. In our advisory committee selection, is there additional expertise that we should integrate into our advisory committee appointment? Are there new or changes in methods needed to support the evidence review? And so we've talked about with precision nutrition, advances in our food pattern modeling and or integration of system science applications into the process to be able to address additional factors. And the third step, of course, based on the preponderance of evidence, then we integrate these topics into the dietary guidelines as appropriate, and then they can be implemented in that fourth and final stage. Now, where we think we are in this phase around precision nutrition, particularly related to genomics, the microbiome is still in building the evidence base. And there's an exciting research project that I just highlighted here, Nutrition for Precision Health, powered by All of Us research program. This is a program funded through NIH. Super exciting. There was the opening session at Nutrition 2022 had a very nice panel discussion around this research program. I'm not from NIH, but if you Google Nutrition for Precision Health, this just pops up. And it's really still relatively early in that process. I think they plan to have protocols completed by the end of this year. And it's a multi-year program to really explore data collection to inform this larger research program. So we, again, really feel like we're still building that evidence base and on the front end of thinking about more integration of precision health into the dietary guidelines. Now, one thing I do want to kind of, in talking about this precision nutrition conversation, do want to take a step back and just say today, even though we don't have this work on precision nutrition, improving dietary intake across the US today is critical. It's not as though Americans or people in the US eat a healthy diet and we have high rates of chronic disease. About 6 in 10 adults have some diet-related chronic condition. And the right-hand side of that slide shows adherence to the dietary guidelines. So these are healthy eating index scores, and healthy eating index is a tool that has 13 different components. It measures alignment with the dietary guidelines with a score from 0 to 100. The average score with 100 being the closest alignment. The average score in the US is a 58. So as a general statement, there's a lot of room for improvement. And we don't think we're in a position where we can wait for more precision nutrition information. We think we need more activities to support implementation science and to support more nationally representative data and other research on other topics as we consider to explore this conversation. Now, what we do see that the core elements that make up a healthy dietary pattern have remained remarkably consistent over time, across the life stage, and across populations. There is remarkable consistency, and that's language that was actually from our 2020 Advisory Committee report. It's remarkable consistency in these core elements. There are different ways there are different fruit or vegetables or different ways to consume this package of foods, but there's remarkable consistency in the core elements of a healthy diet. So while there may be some ways that we need to refine those individual tailored guidance, we do think that a diet rich in fruits and vegetables, low in added sugars and sodium is something we should do at a more, continue to promote implementation science to move the needle towards healthier eating patterns. As noted, those core elements we see across different stages of life and also across different health outcomes. So those core elements we saw on the previous slide have been shown to promote health and reduce risk of chronic disease across a number of health outcomes. So these are the outcomes with moderate or strong evidence in the systematic reviews cited in the 2020 Dietary Guidelines Advisory Committee report. And as you can see, it's not just one health outcome. We see these core elements of a healthy diet kind of picked up across many different health outcomes. So you don't have to eat one way for cardiovascular disease, another way to help prevent cancer, but there is a lot of remarkable consistency. So personalized nutrition in the dietary guidelines, either or both. We do think we're at a place that more research is needed, but we also think that there's often statements that the dietary guidelines is one size fits all. And we really think that misrepresents the guidance. The guidance is really, yes, it has core components, but it's intended to be tailored and customized across a number of factors that are already in this personalized nutrition space. Again, may there be more factors that we consider in the future? Well, probably likely, but we already have some of those elements built into guidance. So the core elements of healthy eating have remained consistent. However, while research explores this topic, as well as many other topics, we really want to continue to support shifting current dietary intakes to healthier dietary patterns. Okay, so before I wrap up, I have to acknowledge that we have kicked off the process to develop the next edition of the dietary guidelines. We took that first step of identifying potential questions to be examined in this edition and posted them for public comments from mid-April to mid-May. We're in the process of reviewing those public comments and also considering research availability as we prepare for this round of the dietary guidelines revision. We currently have a call for nominations open. If you or someone you know, or if you would like to nominate someone for the advisory committee, now is the time. And that nomination period ends July 15th, and we really welcome those nominations. When we are selecting our advisory committee, we are looking at a range of different factors: professional experience, education, expertise, but we're also really working to support the establishment of a committee that is balanced and reflects the diversity that we see in the US. These are some of the topics at the committee. We are working to refine the questions, but some of the topics we expect to pose to the committee. A few of these are new. Ultra-processed foods is one that we have not addressed directly in the past, and that is a topic that we are proposing for this round. And an increased focus around weight management, largely because of the high prevalence of overweight and obesity that we see in the US that has so many implications for other health outcomes. So if you're interested in the dietary guidelines process, I really encourage you to sign up for our listserv at dietaryguidelines.gov, where we do promotions about different activities and opportunities to engage throughout the process. I'll also note that we have a number of resources available at dietaryguidelines.gov, including all the information around nominating a potential advisory committee member. If you're interested in the systematic review piece, nesr.usda.gov has complete systematic reviews for the different topics that are examined by the advisory committee. And if you're interested in how to tailor the dietary guidelines, one resource is myplate.gov. So I thank you, and I look forward to the discussion panel.
Thank you, Dr. Studi. Our next speaker is Dr. Angela Odoms-Young. Dr. Odoms-Young is an associate professor and director of the Food and Nutrition Education in Communities program in the Division of Nutritional Sciences at Cornell University. Dr. Odoms-Young.
Good afternoon. I know it's hard coming right after lunch, but I'm excited to talk about this kind of where personalized nutrition or precision nutrition and dietary guidance meets the real world. And so when we think about implementation, particularly for those populations that may be disproportionately at risk with this equity lens, how do we achieve it as we sort of move into this more advanced level of applying science in both practice and community? So these are my disclosures. I think the biggest disclosure is this year I'm ending as the equity scholar at Feeding America. At the end of the year, I have funding from NIH. I'm on the NASEM Food and Nutrition Board and participate a lot in community boards, thus my real world focus. And I'm an employee at Cornell University. So before we start, Cornell actually acknowledges any place we go that Cornell is located on the traditional homelands of the Guyacono, which is part of the Haudenosaunee Confederacy. And so part of this idea is to think about the idea that our past actually informs our future. And partly as we think more about precision nutrition, these factors become relevant. How do we think about equity in the context of nutrition science? So I have two requirements or two things that I've been charged to talk about. One is, what are some of those considerations and challenges? So what are those important factors when considering personalized or precision nutrition in low income and low literacy populations? And then what are some of those opportunities that we have? We know that poor diet, as was discussed, and related dietary risks, like other outcomes, including food insecurity, limited food access, is part of the American landscape. We have a lot of literature to indicate that. And that current recommendations have had limited effect. Why it's had a limited effect, though, is a little bit debatable. So is it in the idea that we need better recommendations that are sort of, sorry, I'm like moving fast, but that are focused more at the individual level, more personalized, or is it in implementation, or is it in both? I think most of us would argue that it's in both. Most population strategies to improve dietary behaviors has focused on a one size fits all. So we have public health recommendations, but really those public health recommendations can be tailored to the community or individual family level. But in a lot of ways, we've used a one size fits all approach to do that tailoring. Increased healthcare costs, as was mentioned, the rise of chronic disease is really why we're interested in moving into this area. And then also, which was mentioned before, the idea that adherence across the US population to dietary guidelines is really low. I mean, when we think about the consistency of these guidelines, the fact that we, in some cases, have many people that are not meeting these guidelines, is that what is the gap here? What do we need to do next? And with some areas, so we see limited food and beverages. Okay, sorry, this is like, I'm like technologically not doing well here, but limited foods and beverages. So we have higher intake in added sugar, saturated fat, and sodium. I think sodium is really striking. And a lot of this is related to the food supply, where 90% of folks exceed the chronic disease risk reduction limits for sodium. That's extremely high. It's not the salt shaker. It really is in the food supply that you see that's driving that. 77% when we see exceeding the limit for saturated fat, 63% for added sugars. So if we look at lower income households, really it's been consistent that income is associated with poor diet. We see a higher risk in certain populations, but as I mentioned, the mechanism linking these individual, family, community, and economic conditions and dietary behavior is quite complex. So this is a paper that looked at trends and disparities in dietary quality among US adults by SNAP participation status. And one of the things that, and I know it's small, that it indicates, if it looks at ideal diet, intermediate diet, and poor diet. So people that participated in SNAP actually had poor diets than non-participating. equivalents if you look at sort of the comparison. And some of this, people say is SNAP related to poor diet. No, SNAP is not related to poor diet. That potentially people may be more at risk, those that are participating in SNAP and other food assistance programs, and then of course compared to their higher income counterparts. So what is causing this poor diet? And again, we can't say food assistance is associated with poor diet, because actually food assistance can help support improvements in diet. But there is something happening here in a low income population that may be participating in food assistance that's creating risk. And then we also see the same when we think about income and food insecurity. And so food insecurity is defined, for those that may not be aware, is you have uncertain access, economic access, household access, where you may fear that you're going to run out of food and not have money to buy more. And we see consistently income associations, with lower income associated with food insecurity. But we also see other groups, household with children, and also African American and Latinx households, African American households and Latinx individuals. So we know that this concept of food insecurity, for example, and other factors that may be linked to risk are not only physiological. So we see physiological effects, and food insecurity is an example of that, where you have adjustments to normal food use or reduced food intake, nutritionally inadequate diets, but it also has a psychological effect where you have food anxiety, feelings of deprivation, potentially a deviation from social norms, social exclusion, and we know social connectedness right now is a big focus when it comes to health. And then a managed process where there's even maybe stress that's associated with managing that process of finding food. So precision nutrition, and as was mentioned, this definition that can be quite complex. So it's not only diet, but it's the context around diet, which also may be creating risks. And so this is from the NIH strategic goals, and looking at to spur discovery and innovation through foundational research, to think about dietary patterns and behaviors for optimal health, look at nutrition across the lifespan, and then reduce the burden of disease in clinical settings. And I think, as Dr. Seibert mentioned, that a big focus of this has been on omics. But how do we kind of bring together omics in the real world? Because we know that there are other factors that are potentially impacting diet and maybe even risks. So we think about choice commonly. Does somebody choose the hamburger, or do they choose the fruits and vegetables? But we know it's a lot more complex than that. People actually live in communities. They don't live in a lab where you give them two choices and they pick, okay, I'm going to pick the hamburger, or I'm going to pick the fruits and vegetables based on what you told me. You told me the fruits and vegetables are good, so now I'm going to choose it, right? Does that happen? So a lot of work has been done in public health to think about upstream factors. And then the precision nutrition conversation has actually been more downstream in a sense. So we know that there's been a big emphasis on healthcare, individual health education and case management, clinical practice, and thinking about the link between risk behaviors in mortality or morbidity, where we see that a lot of upstream factors, and we have extensive body of evidence that's showing that living conditions, so your physical environment, whether you're in a neighborhood where you have access to stores, where you have access to fruits and vegetables, are you in a neighborhood where you lack access? Do you have income to purchase those? And then other factors, employment, policies as it relates to healthcare and payment. All of these things are factors when we think about implementation, and we know that they play a role in people's life chances. And so life chances impact choices. So what are some of the challenges in thinking about precision nutrition, as well as population-based guidelines in low-income communities? in families. Part of what precision nutrition is thinking about is the individual. What's your individual risk, and how do we tailor individual recommendations? But actually, people, as I mentioned, they live in families, they eat in families, they eat in communities. And so it makes it difficult. What happens if essentially you have recommendations that are very different than other people in your family, because we eat in the context of families. We're in the context of community. This is a systems model, some work that's been done to look at the dynamics of the complex food environment underlying dietary intake in low-income groups. It's a systems map of associations extracted from umbrella literature review. And it's sort of hard to see. I know it's like very small, but it mentions some of these factors that I talked about. So this systems map was actually done at different levels. It was done looking at geography, so where people live. It was looking at income and household economies, family and social norms, perceptions and beliefs that people have, to look at these layers of influences. So partly when we think about things like the microbiome or genetics, can we develop tests or assessments to meet a lot of these factors that play a role potentially in what people eat, how they eat, but then also, as I'm going to talk about further, their stress, which may contribute to other factors like the microbiome. So mostly what we have when we think about implementation, and most of our food assistance programs are targeting low-income populations, low-income families. And not only the implementation at the family level, but what about at the community level? These programs are implemented by people, not technology, or it's not automated. And an example of that is CACFP, and I work a lot with childcare providers and thinking about the meal-based pattern. So the meal-based pattern is informed by the dietary guidelines, but this actually gets implemented at a childcare center by real people. And thinking about meal patterns, so how do you take this meal pattern? This is an example of a meal pattern that a child care provider will apply. So how do we look at precision nutrition in the context of the application of these meal patterns at schools, at child care providers, or at child care centers? So this has to be implemented in the real world. And mostly it's been talked about in clinical care. But most of our DGAs really are applied to population-based planning, in addition to individual family level messages. So how do we think about precision nutrition in more population-based planning in food assistance? And then, although largely there's been a focus on the healthcare system, when we talk about low-income populations, could be a challenge for several reasons. One is inconsistencies in quality and access and data. So not only different levels of access to care at the individual level, but different levels of infrastructure when you look at different healthcare systems within communities. And there's been a lot of work around that. Implementation issues, technology issues. This was a survey that was done around precision medicine of healthcare leaders by Definitive Health, where they asked about their greatest challenges to implementing precision medicine. And some of those challenges will also be related to precision nutrition. And I won't talk in detail because of time, but education of providers, which was mentioned before, but also the infrastructure within the system. In these broad disparities when it comes to access, we know that low-income populations have less access to healthcare, and part of this is insurance. So are we going to create sort of a different level of access within systems where some people have access, which already have access to better care, to these recommendations? So about 31 million people of all ages in the United States are actually uninsured. And for some, this is like persistent level or periods of being uninsured, where people are uninsured a year or more, or for unknown duration. Like the majority of the people in the uninsured population are actually uninsured for long periods of time. So, which Dr. Steiber touched on, is this idea of payment. So right now we know that medical nutrition therapy can have some impact, but in the current system, the reimbursement level for that is limited. And so there's a lack of Medicare coverage for effective nutrition care services. And a lot of this is rooted in policy. So under the current law, Medicare, which is sort of the, if you think about nutrition recommendations, Medicare would be sort of that ideal place to support those recommendations when it comes to policy and payment, but it only covers outpatient medical nutrition therapy services provided by registered dietitians for those with diabetes, chronic renal insufficiency, non-end stage renal disease, and post-kidney transplant. So we don't have sort of across the board, even with the current guidelines, that we have policies as far as payment. So I'm going to kind of move forward, because this is the sort of story where we have income and when we look at racial and ethnic minority groups, we see a higher level of risk in those populations because of the overrepresentation in the low income population as well as others. So what should we do next when we think about these models? And what we don't have is really understanding the link between these more social and structural determinants of health and more biological processes. So part of this idea of looking at low income populations is that you have this response or stress response that's actually having an impact on behavior, but it's also having an impact on more, we think about these bio-behavioral mechanisms that go along with things like coping. And then, of course, we haven't talked about lack of sleep, but this idea of stress in the context. So you have this actually behavioral, but also this more physiological or biological impact. So one potential opportunity to look at both of these is in WIC. WIC is a federally funded program that aims to safeguard low-income women, infants, and children up to the age of 5 who are at nutritional risk. And there's already a focus on providing things like motivational interviewing and taking more general guidelines and applying them in individual food packages that are food prescriptions. And a lot of people don't always think about WIC as being, they think of it as sort of this more generic food assistance program, but there's actually individual food prescriptions that are implemented, even though it's in the context of this broader food package that is part of those policies of sort of allowable foods. It's also, people don't always think about WIC as a short-term intervention program at a very critical period, early life. So the focus is not only to provide food, but it's also to improve health status and improve lifetime nutrition. It takes a life course approach. And so it's really, if we think about these population-based recommendations with the DGAs and then more individualized application, WIC is a great option to really test some of these. And so what can we do to really be more thoughtful as we move into this application? One is to be nimble and flexible, implementation science, and then really building researchers that can look at both with equity at the center. And I think that's particularly important, because if we use genetic information, although 75% of the global population is of Asian or African ancestry, we really actually have limited information in the database. Existing genomic databases are largely comprised of individuals of European ancestry. And so I'm going to actually just end because I'm running out of time. But one piece of this is stakeholder engagement. What do real people with a lived experience what impact can they give about directing some of these efforts? And a lot of this has happened in precision nutrition. And so, I mean, in precision medicine. And it's important that we do that same groundwork in precision nutrition. And so I'm going to end there. Thank you.
Thank you, Dr. Odoms-Young. Our next speaker is Dr. Bruce Hamaker, who is a distinguished professor of food science at Purdue University. He will provide a practical example of how we might address both personalized and population-based benefits at the ingredient level. Dr. Hamaker.
Good afternoon, everybody. I'm happy to be here. So I'm a food scientist, and I think this talk's going to be a little bit different, but it's in the same topic. I'm a food scientist, but I have a nutritional biochemistry and biology background. And so what we do is really to look at food and food components. I would say more towards the food components and their intersection with the body into physiologic and metabolic systems. And I'm going to give you sort of a little different take. I would say it's my take on, and my group's take on precision nutrition, and related to the possibility of using that approach in foods to get a population effect. So, you know, the same effect in everybody, maybe not everybody, but a high percentage of people in the room. And I'm going to give this prebiotic fiber blend as an example. So I need this, right? Yeah, disclosures, conflicts of interest, a few things there. I'm obviously faculty at Purdue, but not getting into those. I'm on a few advisory committees in addition to IFANS, some consulting. We have research support from the federal government and industry both, also foundation I didn't put on there, Rockefeller Foundation, and have a small company that's not doing anything right now, but who knows, you know, right carbs. So precision nutrition, it's been talked about, and I think from the nutrition science perspective, and I'm not breaking this, I don't want to break this apart into silos, to your point. You know, I think these are complementary kind of views. But from this perspective, it does go towards this, that one size does not fit all, right? And there's a validity in that too. And it can lead all the way to this idea that you can personalize a diet. It's been talked about a little bit through monitoring diet composition, sensors, so forth, AI learning, you know, ultimately, right? And then tell you what you should be eating for better health. That can, that can happen in a group, for a population group also, but it really goes down to that personal level, the individual. But one can ask the question also, is it possible to design foods that make individuals respond in the same way? Okay, so, and I'm going to tell you kind of how we think about that from the precision nutrition point of view. That's precision nutrition in that how do foods then, as I mentioned, intersect the body? We study carbohydrates. I'm going to talk about prebiotic fibers briefly as an example, but we also study glycemic carbohydrates and how they can be made to activate systems in the body related to, say, appetite or other in a precise way. So, sorry, I don't know how that's happening, but this idea that foods can give the same response, and not all could, obviously, but addresses this inter-individual variability in the way that making, say, really precise foods that are going to then affect people equally. in order to do that, one really has to approach this from a kind of mechanistic point of view. Really what's needed is, at least to some point, a mechanistic understanding of how that happens, right? And as a public health initiative, to Angela's talk, it could have a broad effect, right? So let's go on. I'm going to give you this, and my challenge is to not go down the rabbit hole into detail, which I won't do, but if I do, raise your hand and wave at me. I won't though. So here's an example that's targeted prebiotics. Prebiotics are food for bacteria in your gut, right? And I'm going to talk at the end about a prebiotic fiber blend that we think can do that and have some evidence that can happen. So that's something that you wouldn't have in your minds, right? Because in this room, probably every one of you is thinking, well, my microbiota, my bacterial community is different from the person sitting next to me, and it responds differently to different food. We know that. So I'm going to tell you a way that perhaps you can go towards that, the kind of structure, kind of food that's going to give the same kind of response. It's related to this on the right, and it's this simple idea that we've been working on for quite a while now, 10 or 15 years, is that one can get an understanding how fiber structures, carbohydrates, right, align with gut bacteria, even specific bacteria or bacterial groups, and that can be used to support those groups, okay, or support individual bacteria. So here's going down the rabbit hole, but I'm going to show you something kind of simple out of this, and that's that yellow box. And it's an example that there are fibers that do that. So this is an insoluble beta-glucan. It has a particular chemical structure that's kind of unique. It's not oat beta-glucan. And it specifically feeds that bacteria. I'm sorry, this is relative abundance plots for genera in your bacteria in your gut. So that gray one is the example here. So in a 24-hour fermentation, that particular food, that insoluble beta-glucan, is increasing the relative abundance of that bacteria from less than 0.5% to over 20%. It's like just, you know, that bacteria can use that better than any of the others. Just think of it that way. And that happens to be a butyrogenic bacteria that even some groups are trying to make into a probiotic, so an oral probiotic. So it's recognized as a beneficial bacteria. So it leads down to this kind of idea that one can get targeted effect of carbohydrates if you align them correctly and have prebiotics that work something like probiotics. But now let's get back to what we're talking about. And I just actually have a few more slides. How do we get this business of everybody reacting the same, the microbiotic communities reacting the same? Well, it so happens that the more aligned, the more matched that carbohydrate is to that bacteria in its support, the more it acts equally over everybody. And that's because it sort of doesn't matter what the community structure looks like because it's targeted to that bacteria. Okay, so on the other side of it, that simple fiber structure, you can think of like a fructooligosaccharides because it's one of the simplest carbohydrate structures. Lots of bacteria want to get at that. And the reaction in your gut depends on the community structure. So you get all kinds of different reaction, effects, responses is a better word. Okay, so this is a kind of precision nutrition approach by matching these fibers to the bacteria, so you're getting a common kind of response. And here's just quickly that kind of response, back to the same beta-glucan and that same bacteria. bacteria anaerobe stipes, that butyrate producer, in 10 different donors, they all responded. That bacteria all, supported that and promoted that bacteria. And the two on the bottom, those individuals didn't have that bacteria. So you got to have the bacteria, right? Or you'd have to take it as a probiotic or something. But fructooligosaccharides, you get a different kind of response, differing responses in different people. And if you put the y-axis on the same basis, you see that you get a more robust response. So it's a kind of a faster response. So finally, this idea, just a couple slides, of blends or mixtures. The same approach of alignment can be done towards groups of bacteria. And so what we've done is to identify fibers that support key important core groups in your gut and mix those together, right? And this is called a heat map if you're not familiar with it, but these are the 4 kinds of fibers on the top, and the red means the promotion or support of those bacterial groups. So you can see there's distinctly different groups supported by the 4 different kinds of fibers, right? And they also have different metabolite outcomes. Different, one produces more butyrate, one produces more propionate, like that. And we found in a clinical study with my scientific partner, Alika Shavarjan at Rush Medical School in Chicago. And this happens to be in Parkinson's disease patients. Sounds kind of odd, but Parkinson's disease patients have dysbiosis. And you find it in a lot of disease, chronic disease, non-communicable disease kind of conditions. So in just 10 days, we saw nice effects. For one thing, I would say at the top that fibers have to be tolerable. So this is like a big thing for us first. It's got to be tolerable. We do a tolerability test too, because if they're not, people don't want to eat them, right? So, but anyway, in 10 days, it promoted a healthier balance of bacteria in the gut, increased gut epithelial health, which is related to that zonulin, serum zonulin in that bottom right box, which was pretty amazing in 10 days, and improved perceived wellness scores. So this is just the beginning of it, and hopefully it will, in future clinical studies, we're doing a human supplementation study in the early fall. And hopefully it will show that again, that if you really approach this right, you can get very effective prebiotic fiber mixtures or even individual ones that affect people in a similar way. So I think I don't need to say anything there, only to say that you can think that this isn't going to work with all kinds of foods, but I think there is an opportunity there to understand, at this, again, intersection, mechanistic kind of view between foods and the body. Are there ways to get foods that really produce better results over a population? Thank you.
Okay, thank you, Dr. Hamaker. So if we'll have our speakers come up, we'll start our discussion now. So we actually will first have, see if you have any questions in the audience. There's a microphone right behind you.
Hi, I'm Felicia Wu, Michigan State University. A question for Dr. Hamaker, and I'm sorry if you covered this and I missed it. How exactly would that type of specialized fiber be incorporated into the diet? Is it in the form of a pill, something to be added to food? How would it be done? Thank you.
Thank you. It's a good question. And I mean, our thinking right now is as a supplement, and in fact, in the study we're going to do in the later this year. It'll be in the form of a bar, 10 grams in each bar. Angela brought up a really good question when we met before. Do these exist in foods? They do. These are very common fibers. And can nutrition education be given so that people just actually just consume these in regular foods? I think it's a possibility too. But we're working towards the supplementation. Yeah.
Thank you. Do we have any other questions from the audience?
So
Thank
hi, this is for anybody, I guess. So when I think about precision nutrition, I look around the world and I look at all of the devices, basically electronic devices that are being built. And I'm wondering, one, are you monitoring those? And if so, do you see how you might help facilitate making those better? Because ideally, they'll make it easier for people to choose foods that'll be healthy for them.
So I can give that a shot. My research team does not routinely and systematically monitor devices. We do look, and that's why I showed that one scoping review in which we looked at the amount of evidence, and we also followed that up with systematic reviews to look at the effectiveness of those devices on changing behavior and changing outcomes. So while we don't individually monitor the devices or think about how we can have an impact on changing those devices, I do think what we think a lot about is how can our practitioners leverage those devices and use them in conjunction with other educational tools to help their patient be more effective in changing behavior. So I don't know if anyone else has a response to that, but it's probably not exactly what you were looking for.
Anybody else?
Yep, I have one.
Okay.
I'm Johanna Dwyer from Tufts University Medical Center. And two questions, actually, one for Dr. Stever and one for Dr. Hamaker. For Allison, I wondered if you could speak at all to the issue of scale. There's the issue with getting all of, and it also applies to all of the talks. And I go back to a study that was done in the European Union, the Food for Me study, where they combined some counseling with a lot of automated stuff that really did seem to make a difference, and in a good way, and wondered what you thought about that. And then for Bruce, just a question about whether you've gotten to the stage yet of trying to feed the supplement with, or the food, the bar, with other foods, and whether you can still target with all of these other things coming in at the same time, and also how long the effect might be. Would it have to be a constant effect to keep the, I've done more of those studies than I would like to talk about.
So in terms of scale, I'm Johanna, I want to make sure I'm answering the question correctly. So scale in terms of being able to have more access to, or scale in terms of creating a program and then scaling it up so that that program is being able to, be met all over the country. I'm not sure exactly. Both. Yeah, exactly. Exactly. So I kind of think there's two main things here. The first is obviously funding and finance, but the second thing is the capacity, the workforce capacity. And I think both those things are super important. If we could wave a magic wand and provide nutrition care to all those who need it, regardless of funding, I don't know that we'd have sufficient numbers of practitioners, neither exercise practitioners nor nutrition practitioners. And so I think we both have to figure out how to improve access. And then once we have a way to do it, and as Angela so nicely pointed out, have a funding mechanism for the individuals who provide that. And then we have to think about how to increase the number of practitioners. So, and maybe it's making more layers of practitioners, maybe it's engaging and using different types of practitioners, but I don't think that this problem can be solved without a multidisciplinary approach and thinking about changing the infrastructure of the system in a way to provide better access to the individuals who need it most. And I think that's the crux of what I think is challenging about the precision and personal nutrition issue, is that the people that need it the most probably have the least access. And I don't know how you change that paradigm. I think it's a structural policy issue in some ways, but in other ways, I think it's a workforce capacity issue.
And I actually have a comment related to that because I'm interested in scale, things that could be scaled up in SNAP-Ed, or things that could be scaled up in FNAP, or things that can be scaled up in other population models like the charitable food system, for example. Like how can something like an intervention works, and then now how it could be scaled up at the community level? Because on one hand, in public health, we've been doing all of this work about social and structural determinants of health. And then now we're talking about sort of precision nutrition, and these kind of have to come together at some point, because I think the study you mentioned is an excellent example. And I've been really curious, who was in that study? You know, what type of access do people have that are in some of these studies where and of course, we're early on in a lot of this work, but I'm curious if we start taking these studies to the broader population, what's going to happen? Will we learn more when we see people across different environments, different constraints, different resources, sort of that study in the context of understanding the social and structural determinants of health is where I think we'll learn a lot. So I really like that idea of scale up. I'm very interested in the scale up and how we can incorporate that in some of the existing food and nutrition infrastructure that we already have that's happening in the United States.
So one more comment about that. I completely agree with thinking about how to use the infrastructures that we have and the programs that we have, and how we can leverage them for scale. But I actually don't think that the Food for Me study was statistically significant. I think that was one of the disappointments. It was multiple countries over Europe, and they found a statistically significant improvement in the counseling aspect in improving health, but the added incorporation of genetic information, I could be wrong, someone can correct me if they think I'm wrong, but I don't actually believe it was statistically significant, the added benefit of genetic information. So just, it's a good example of thinking about it in diverse populations, but also wanting to think about how we make sure we have the evidence to support the addition of these expensive add-ons versus doing kind of traditional personalized nutrition.
And then if I remember your question, I do. As far as other foods, right? Other kinds of fibers in the diet and all, it's an important question for sure. And we don't understand. I'm not going to sit here and say we understand everything about it. We don't. That little study, that clinical study that I showed was that people were eating their regular diets just 10 days, right? But the thinking is that this kind of alignment and matching of fibers to bacterial requirements and utilization, that should work with other fibers in the diet also, but we don't know exactly, but the fact that it's better aligned and suited for that bacteria or the bacterial groups we would think hold, but we need to understand it better. And as far as how long it lasts, I don't know. Yeah, either. Perhaps if these are like marginalized bacteria, as some of the healthy bacteria, not to get into the details, won't, but in the gut, in dysbiosis are marginalized. So as they are supported and increase in relative abundance or proportion, perhaps that carries through with a regular diet, but it's just a question, but just in the way that we're thinking.
Yeah, John Erdman, University of Illinois. First, a comment, the continued use of the right side microphone here while we're in DC. I don't think it's a political statement, but we'll go on from there. Bruce, so if you're going to say normalize a population using your fiber supplement so that everybody's sort of the same as far as the bacteria flora, how do we know that it's good for everybody in that population? Some may be good and some maybe not.
Yeah. Well, I'm no expert at that, but I would say that in people who have out of balance bacterial communities, Ali Keshavarjan, in Chicago, he thinks that's a large portion of the population, sort of borderline dysbiotic. Who knows really? But into dysbiosis, there needs to be a balancing out of that. I would say that that's where it can hopefully affect people and should affect people in the best way, that it would bring their communities not back to the same. I don't think it would really normalize so much as create in an ecological sense a balance there, and with the right kind of bacterial groups and bacteria, kind of proportions that relate to a healthy gut. Again, I know something about it, but I'm no expert on that. But I would say that the way that in my mind it is right now, that in many people who have borderline dysbiosis or dysbiosis, it's because there's bacteria groups that aren't being fed well, and over time are really need to be built back up.
Thank you. We'll now take some virtual questions.
Okay, so here's a question maybe mainly for Dr. Odobsjang, but anyone else could pipe in as well. So the question's in thinking about health equity and access, the reality is we have a lot of European data. And if we're trying to understand subgroups and more, maybe not personalization, but these subgroup differences, what can we do about that? Or what would be a strategy to address that?
So in all of us in the precision medicine, that paper at the end that I showed, Kareem Watson and colleagues, they developed a model for sort of community-based. A big focus is getting people into these studies and into, you can't get data from people that won't come into the studies, basically. So part of it, and we know that there's a long history of, scientific racism that's created a lot of this, and just exclusion based on access to getting populations. How do we engage populations? And so they have really set a framework that we can use in precision nutrition to start thinking about how do we do outreach to communities, how do we connect with people with the lived experience, and how do we make sure that we engage them in research participation. So I think that's a big focus of it. There's a reason why we have a database that is largely European ancestry. And so people have to understand the history when they go into communities, connect with communities. And there's been a lot of work in that, good work in precision medicine that has happened already.
Okay, we'll take another question.
So this question is thinking about rephrasing the way we have it phrased on the slide there into something like, can personalized nutrition help us achieve population-based objectives? So kind of along the lines of the food for me, whether it was significant or not, but thinking of the relationship that way. That the goal is still the population-based guidelines, but we get motivation from personal information.
I'll just, in thinking about this Nutrition 2022 conversation, this opening session, that was a theme of it. Like maybe it's more an implementation tool. And if someone has something personalized to them, are they more responsive to it? I do think it is the question about families. If each of us have something different, I think it's a question about access. The people who need it most, are they able to get that information? So definitely, I think implementation is an important aspect of it, but it comes back to this, the people we most need to reach, are we going to be able to reach them?
Well, I have oh, go ahead.
I was just gonna say, I think that's the sweet spot, is this combination thinking, whether it's, thinking about our food supply, thinking about good evidence-based dietary guidelines that are implementable and actually testing that implementation and how to best implement them, but then also creating this opportunity for individualized care and counseling, or even group. There's been great evidence showing that you can do group-based counseling that is also effective, and that might help our bandwidth and our scale. So I think these things are all, I think this isn't a one, the solution is also not a one size fits all. It's a multi-pronged, stakeholder kind of solution that we need to come together, doing kind of what IFANS does, which is bring industry and academia and government all together to have these conversations.
Thank you. And I have a question for each one of you that I hope each one of you would answer. So how could each of you envision personalized nutrition having an impact on health? What would be needed, and what is the best platform? What is the best platform? Dietary guidance, healthcare practitioner communication, or food reformulation? Who wants to go first?
It's a big question. I think it's probably a little bit of all of the above. Yeah. And I think probably, from our perspective, a big part of it is thinking about the implementation piece. But I do think it's like with this conversation, we've talked about the factors that you can use the dietary guidelines to tailor. Are there other factors that we need to layer in there? That's going to be, so it's probably a little bit of both, but who is it? Food reformulation, is it? I think it's probably multifactorial.
Yeah, I would say the same thing. I know we're talking about the dietary guidelines for Americans, but everything, there's been a lot of work we think about the European studies or American studies, but there's middle, and low income countries. So part of when we think about precision nutrition, we should be thinking about global. And so I think different combinations of interventions, both policy interventions, individual level interventions, may work in different contexts. And we can even think about some of those interventions in communities. But, I wouldn't normally say this, but I think we definitely have to have some reformulation, even though I'm very much community. It's like you have to have, we have to be able to see and leverage also industry level data to inform this process, healthcare data, industry level data, data that we collect from academia. So, like new studies, but part of it has to we have to figure out what role industry plays and product reformulation plays in that.
Thank you.
I feel like I sort of answered this preemptively. The only thing I would throw in is I think communication is a big piece of this, and thinking about how to communicate to different populations at risk. I think multi-language, different literacy rates, thinking about different avenues of communications, being very local and grassroots, thinking about weight bias and weight stigma. I think we have to be very cautious and considerate as we communicate out to the population that we're trying to influence.
My turn. I think that there's an opportunity here to improve the healthiness of our food supply, with some knowledge coming out of this precision nutrition area. I'd like to see that broadened a bit in the way people think about it, obviously, but I think the opportunity comes through formulations, reformulations, and nutrition education, as you say, communication is what comes to my mind too.
Can I add to that? And also agriculture.
Yeah.
I think we can't forget agriculture in that, in food production and within our agriculture and food system as well.
Okay, thank you.
Another question, please. Probably for the first two speakers. So I'm very much in support of evidence-based reviews, systematic reviews. There is, however, an issue of costs. So systematic reviews are exceedingly costly. You can only ask so many questions. Evidence reviews can help the process. You talked about that, but how can we lower the cost? Because there are so many things we want to know, and there's a limited budget.
So I'll take a stab and then I'll pass it to you. I don't know all the ins and outs of how decisions are made about which systematic reviews are accepted and which aren't. But we have a number of groups and organizations conducting systematic reviews using grade methodology. And Cochrane, the US Cochrane Network is a great example of that, where they've tried to connect all the different groups and institutions that are conducting systematic reviews. And I think we can need to think about that we don't need to reinvent the wheel, that through collaboration, different organizational collaboration, government to nonprofit collaborations, that we can do more. And with agreed upon methodology that is as rigorous as we possibly can, we can think about a distribution of the work in a continuous cycle. But I also think, and you and I spoke a little bit about this, that there are lots of gaps in the evidence. So even when you do the most rigorous systematic review possible, you're going to find a paucity of data in particular areas that are incredibly important to our population. So how do we think about working collaboratively to A, identify those gaps, and then B, fill those gaps so that the next time around, the next cycle around, we have the evidence we need to establish really good guidance?
I have a lot of thoughts on this. One, I think for the guidelines, it's been nice that it is an every 5-year cycle. So in some ways, we're updating for questions that remain high priority. Technology continues to, a lot of things. When we first started doing systematic reviews, everything was literally like, I remember flying and having a stack of abstracts during the abstract review, and now it's all electronic. So there's a lot more of it. I think that's adding a layer of speed. Collaboration, for the US dietary guidelines, we talked to a lot of our federal international partners, communicate about what we're doing, and we are leveraging each other's work. So I definitely think that's part of it. So yeah, I think there's a lot of different areas where, the other piece I was gonna say is assessing research availability before committing to a systematic review. So evidence scanning is still a resource intensive activity, but it's not as resource intensive as going through the full systematic review process. So I think, we continue through technology and additional methodologies and kind of communications and building from one another. They are resource intensive, but we are kind of getting in a place where we're able to move at a little bit more continuous or quicker pace.
And I actually have a question for you on as a statistician who works on some of the statistical methods and measurement error correction with the data. So some of the things, and specifically specializing with wearable devices, some of the things that we see is that sometimes the methods that are being used to actually analyze the data are a bit outdated. So sometimes we actually see statistical significance because we have really big data that are summarized into very simple summary measures that actually, when you use more appropriate methods, we actually see that they're not statistically significant. So one thing I wanted to ask about the physical activity levels that are used when calculating dietary guidelines are, what are they based on? Are they based on self-reported measures of physical activity? Are they based on cutoff points? Some of the methods we're working on and proposing are actually looking more into model-based approaches for coming up with cutoff points to define the vigorous levels of physical activity, moderate levels, rather than using standardized methods. So I just wanted to hear you comment on how the physical activity levels are used in the equations that are used to develop the guidelines.
So, well, first I'll just comment on your general comment about methods used. I think Dr. Steiber commented on using validated methods, and that's something that we should look in our systematic review processes. And is this the appropriate method, and if consider that in the synthesis. The physical activity piece, there's two, and I'll say we don't do the physical activity calculations. We have the physical activity guidelines, but also we have DRIs. And the dietary reference intake for energy is actually underway now. So if you have interest in this, that hopefully will be part of the conversation. But that is more, we have a federal effort led by the Department of Health and Human Services around the physical activity guidelines, and then the DRIs through the national academies. If you're interested, that's is like I said, happening now. So it's very timely.
And actually, a question for it's related to the physical activity and DRIs is, would you recommend the doubly labeled water methods for the physical activity levels, or in terms of when calculating the DRIs, for example, or a wearable device?
I would defer. There are a couple of people here that are way smarter than me when it comes to this particular topic. I think the energy DRI, they're focusing on doubly labeled water. Yeah.
Okay, do we have any other questions, or is it?
We're going to let Chuck get in the last question.
Okay.
All right, very interesting panel discussion. The question I have relates to human behavior. We've got some people with the Fitbit, and they're almost obsessed about everything they eat. Probably not worried about them too much. But with the masses, I imagine if you go on the street, a lot of people only have a vague idea what the current dietary guidelines are, let alone what some of these others are. So how do we move from an academic approach to this one where you really impact human behavior, because people don't always do what they say they will do or whatever, or for various reasons may have limitations that allow them to do some of these things. Some of the suggestions seem to be at a practitioner level sort of thing, and I can understand that, but boy, it's tough to even make an appointment with a medical practitioner nowadays. So how do we do things that would actually get the masses in the direction we want to improve overall health? So I'd be interested in people's ideas.
Ollie, I think we're all with you. Yes, I think you noted like the guidance, it's been relatively consistent for a very long time. And these core components, remarkably consistent. And yet we haven't moved the needle. We have another slide that shows HEI scores over time, and they've pretty much stayed there's been little shifts, but not much. Implementation science is huge. We feel like with the dietary guidelines, there could be a whole nother process that's just looking at how to communicate and how to support implementation. So I have nothing to say other than could not agree more. And I do think our focus, and by mandate, is to focus on what should the recommendations be. But I think it is a very important effort. And that's why we don't want to lose sight. Like, these are all very important conversations. And I think there's a session tomorrow about communicating the headlines. And it's really, you hear about the different groups that do surveys around confusion, like the level of confusion, the lack of trust, the sense of a lack of credibility. I think all those things are kind of compounding right now. So I don't have an answer for the implementation, but agree that it deserves resources to support.
Yeah, I would agree. I think a lot of, so where do you have choice and where is there no choice, essentially? Because, lunch, we had lunch here. Most people probably didn't leave here and go out and eat something else. You went next door and you ate what was provided. So part of that is like reducing the barriers for people to engage. If you look at the supermarket, for example, there's so many products within the supermarket that don't meet the dietary guidelines. And so part of that is wondering, like, maybe we won't ever get to a point where all the products meet the dietary guidelines, but maybe we would get to a point where we have a large number of products that meet the dietary guidelines that people are able, and then we can encourage people towards those products through a lot of different types of environmental design or also messaging. So I think it's almost like a combination, because we can't, like you said, clinical care, I think is so important, but to really make everything be administered through a practitioner is limited. We really have to have community level, like the physical activity. A lot of environmental design has been able to encourage people to be more physically active. And so part of that, how do we sort of structure our environment when it comes to diet to be more supportive, that people are able to make an easy choice, not a difficult choice.
I think that